Today, we're going to continue to talk about gastroenterology, and we're going to start with one of our GI colleagues. I think this is really valuable to have interaction with our clinical partners, and in particularly GI Path, I think is a great place where we can really impact patient care depending on what we see, not just for tumors, but all of the inflammatory lesions. After that, we're going to visit molecular characterization of the GI tumors. And then later this morning, we're going to discover how AI might impact our future gastrointestinal pathology practices. I want to remind all the society members that we're going to have our annual business meeting directly following these presentations. And we hope to conclude everything by about 12:30. So with that, I'd like to introduce our first speaker, Dr. Byron Vaughn. Dr. Vaughn attained his medical degree from Drexel University College of Medicine in Philadelphia, Pennsylvania, followed by completing both the internal medicine residency and a gastroenterology fellowship at Beth Israel Deaconess Medical Center in Boston, Massachusetts. He was supported on a T32 training grant studying the effect of fecal microbiota therapeutics for Crohn's disease. He then took his faculty position at the University of Minnesota, where he also completed a master's in clinical research. He's currently an associate professor of medicine in the Division of Gastroenterology, Hepatology, and Nutrition here at the University of Minnesota. He's also co-director of the Inflammatory Bowel Disease Program and an active clinical and translational researcher with the goal of bringing microbiota-based therapeutics to the bedside for IBD. So welcome.
Thank you very much for that introduction, and thank you for having me. It's wonderful to be here. So yeah, I'll be talking to you about gastroenterologist perspective, so my interactions and expectations from pathology. I do have a few disclosures, none of which are relevant for this talk. I think the only other disclosure I really should just really hammer home is I'm a gastroenterologist talking to a room of pathologists. So I will probably not be teaching you anything about pathology, and I'm not even going to attempt. There's no pathology slides here. So it's maybe a little bit of a different pace than the rest of your lectures, where you'll be getting the cutting edge pathology. If anything, we'll be looking backwards. A lot of my studies have smaller citations. So what I want to get across is to really understand the importance of communication. And we shouldn't be making any assumptions. And communication is really integral in your field and ours. We both need to be making sure we're using precise and accurate language, and that we're conveying the information you need to give us the best information we need. And then we'll go through a couple examples on how communication can be optimized. How does GI view pathology? It's simple. You guys are the gold standard. We don't know what's going on. We get biopsies and we expect you to tell us exactly the diagnosis, and then we can up-to-date the management. That's what we want from you. It's not fair. I acknowledge that. And we do, though, have that assumption, and we do assume that you guys are going to be both accurate and precise, reproducible, and that whoever is on call is going to give us the same answer as anybody else on call, and that we'll be getting the same answers every single time. Obviously, those are unfair assumptions, and there's evidence that pathologists do not always think alike. This is a bit of an older study, but I see it still highlighted a lot in reviews on communications. But there's a low agreement between Japanese and Western pathologists on the diagnosis of gastric carcinoma, something that you might think is obvious, or at least I would have thought that. They gave slides to both Western style and Japanese gastroenterologists. They actually only agreed on 11 of the 35 slides, getting a very low kappa coefficient. And the difference is that the Western pathologist, I'm probably preaching to the choir here, but you guys know this, the presence of invasion was the most important feature, whereas the Japanese pathologist really favored nuclear features of glandular structures as being more important for a diagnosis of carcinoma. And so this has led to a number of classification schemes for diagnosing gastric carcinoma. Now, in today's day and age, I think we have learned that some of these nuances may not be too clinically significant, although there still are these kind of high-grade dysplasia, suspicious for carcinoma, that may get managed a little differently depending on where you are. In Japan, they're more likely to go for an ESD, an endoscopic dissection. Whereas here, we still will resect them. Some of the low-grade lesions also may get dissected, whereas we may observe some of the low-grade lesions, although we are getting more and more aggressive. But I think having a clear understanding of exactly what we're meaning when we're saying this, and, is this suspicious for carcinoma, is this low-grade, and what is that ultimately going to mean for the natural history of the patient is really important. So it is important for us on the GI side to understand that there are varying classification schemes, and it's important for, I think, pathologists to let us know what classification scheme you're using, and locally that there's agreed upon best practices for these things. And so that kind of, gets us to the most important point of this talk, and that is that we need clear language that facilitates communication. So communication is the key. There's sort of three areas that I think we think of when we talk about gastroenterologists interacting with pathologists, and that goes from sampling, which we do, morphologic evaluation, which you do, and then reporting, which you give back to us. Sampling is our job, but I do fully believe that we do it better when we get feedback from pathology. And we'll see in the examples, I think, how that can be really important. In general, we know that more biopsies are better. So one example would be esophageal cancers. We know that there's an increase in the diagnostic yield when we go from 2 biopsies to 8. So I think getting feedback when there's insufficient biopsies is really important. And if we repeatedly see insufficient biopsies, letting us know that, hey, as a system, you should be taking more biopsies. And then I think it's really important to have accurate labeling. I'm sure you guys have come across a lesion where it's not clear if this was a polypectomy or a biopsy of a polyp. And that can be really frustrating from your point of view. And then when we get it back, it can be frustrating because, we just did, 30 cases since we're reviewing that path, and we don't exactly remember what we did, and maybe we didn't document it the best. So I think making sure that, when possible, we're creating systems that have very accurate labeling. And we do this on our side with now hard stops at the end of our endoscopic procedures to review the pathology before it's sent. But truthfully, there still are errors. One example that I find to see a lot of variation between gastroenterologists is that a lot of gastroenterologists, when looking for microscopic colitis, will just take random biopsies of the colon in one jar and send it. I was trained by pathologists when I was a fellow to break that up into the right and the left. And there is good evidence that actually the diagnostic yield differs throughout the colon. And so some areas it's as high as 97%, but if you're just on the left colon, at best it's about 90%. When you just have random colon biopsies, one jar, about a diagnostic yield of 96%. So this one group has proposed, really an ascending descending protocol, which reinforced what I was taught years ago to do right and left. And so this is, again, I think a field where it can be helpful to give feedback to the gastroenterologists for their sampling protocols. If you're getting some unclear pictures and you're not able to really say, yeah, I think this is microscopic colitis based on, just some left colon biopsies. This is not evidence-based, but in my opinion and everything that I see, you need usually a minimum of 6 bites to make a diagnosis. And I'm sorry, minimum of 4, but 6 is usually better. So when I'm teaching fellows, I always tell fellows, look, try to at least get 4 bites, but 6 is usually better. And that's just my rough cutoff. And I do sometimes see that we'll get feedback on and I like this, our pathologist will sometimes say, there's really only 1 sample. It's a kind of insufficient tissue to make a diagnosis. And that's really helpful for me to make sure I'm always going back and getting plenty of samples. Morphologic evaluation, this is what you guys do, and I'm not going to go into this too much, but I think we want to be both the language to be relevant and reproducible, and we trust that you guys have systems to decrease intra and inter observer differences, and we expect this to happen internally. So my expectation is that pathologists are doing this locally, that the group is figuring this out, and when there is disagreement, that they're having it reviewed by other sets of eyes internally. Reporting is where we're going to spend the rest of the talk, because I think that's where we interact the most. And so, we kind of need perfection, right? We need no more or no less than what's needed to make an accurate diagnosis, prognosis, and management. And also at the same time to convey uncertainty, which is, I think, a challenge in pathology reporting and a challenge for us. there are substantial variation in pathology reports. So an older study in Wales found that over the whole system in the country, that very few pathology reports accurately had all of the agreed upon parameters in their path reports. And for colon cancer, about 3/4 had minimum reporting criteria, but only about half met the minimum standards. Now, that's an old study at this point, but a more recent update from Scotland really didn't show that much improvement, which is a little disappointing. And so we have seen a trend, and you working on the reporting systems are more aware of this, but I think there's a trend over time from narrative reporting to what's called synoptic reporting, where you have checkboxes and multiple choice and fields that you have to fill out. The traditional narrative report would have 3 sections: macroscopy, microscopy, and a conclusion, and it was all free text and frankly prone to misinterpretation and missing information. A synoptic structure allows for standardized language, multiple choice answering for mandatory parameters, and automated generation of conclusions, which can be very helpful. This obviously, when studied, results in an increase in your mandatory parameters because you have to put something in to complete the report, but also a decrease in missing, so non-mandatory parameters. So where do we see the most benefit for this? When cancer types, the narrative reports are very good at tumor type, grade, invasion depth, and nodal status. Changing to synoptic reporting helped with other parameters such as vascular or perineural involvement and the number of lymph nodes. I think some of these things get really important for GI. For example, if we take off a large polyp that has cancer in a polyp, there's a lot of extra things we're going to want to know about that, involving the depth, the lymph node involvement, the vascular involvement. Where exactly was this? Do we need to have this person go for a cancer surgery, or can we survey them? A very challenging clinical situation that I think we want a lot of interaction with pathology. The problem, though, is that when you move to synoptic reporting, it really it looks great on paper because you have all these multiple choice questions, but what do you do with uncertainty? The fact of the matter is not every pathologic specimen is going to be able to easily fit into those criteria that you have. And so what do you do with uncertainty? In the 90s, there was a lot of literature on this, and it was really fascinating. There was this one study that examined the pathologist's use of phrases and then the surgeon's preferences for the phrases. I think there were not a lot of endoscopists at this time because we probably weren't taking biopsies. The scopes hadn't advanced yet. So surgeons love the phrase diagnostic of. They felt the most comfortable with that, but only about half of pathologists were using that routinely. In keeping with was something that pathologists use frequently, but the surgeons really did not like. The majority of surgeons do not like the phrase in keeping with. Consistent with was better. People do like the phrase consistent with. Highly suggestive of was kind of lukewarm, Suggestive of, which pathologists like, surgeons really did not like. So it's fascinating that the words you use will have, you are conveying one meaning and the receiver is getting a different meaning. And so conveying uncertainty, or this idea of linguistic acumen, is really important. And I think pathologists are likely aware of this. I hope are aware of this. And if not, you'll hear it now. A couple quotes I came across in some literature. Pathologists are both particular and inventive in the phrases they use. I thought that was nice. And there was one quote that I'll read. There is no place for the pathologist who expresses individuality by subjecting unsuspecting patients to uncontrolled diagnostic self-expression. The same study quoted a veterinary pathology study where they found 68 unique terms to convey uncertainty, and they note that they didn't have a comparable human analysis. But there's a lot of ways to convey uncertainty. So how do we do it, and how much of a problem is it? One large academic center reviewed this and found that about 1/3 of their pathology reports contained some expression of uncertainty. When they broke it down, the 2 most common phrases were consistent with and suggestive of, but then there were another series of phrases that were there. And the receiver, me and our surgeons, we associated certain phrases with an increased certainty for diagnosis, which you may or may not have intended to convey. In general, consistent with and highly suspicious were phrases that I think both pathology and surgeons, endoscopists use to receive diagnostic accuracy. However, favor was one that the surgeons really thought, was very similar to highly suspicious, but the pathologist actually really meant to say more of a suggestive of, kind of more of a waffle. So this one single study, albeit, and certainly retrospective, highlighted the importance of using the word like favor really has two different meanings. When they looked at predictors uncertainty, so first, age and gender did not predict use of uncertainty. So it's not like the older docs or the younger docs are more likely or less likely to use uncertainty phrases. As expected, probably, this biopsies, much more likely to have phrases of uncertainty than an actual resection specimen. And then cancer, much more likely than medical diseases, was more likely to convey uncertainty, because I think the stakes are higher and you don't want to make a mistake, and you want to be very precise with a cancer diagnosis. Notably, 20% of the uncertainty was trivial. So it had nothing to do with the management, and it was clearly a benign etiology, but you're waffling on if it's a lipoma or a ganglion cyst, and frankly, it just doesn't matter. But when we see that you waffle, we then get uncertain. Well, is it a lipoma or a liposarcoma? What are they concerned about? So I think there is some room for being definitive in a benign etiology, even if you're not sure what it is. And then another 20% were really related to subclassification, which again may not be that important. So I think how you're if you're conveying uncertainty about a couple of different benign etiologies, let us know. Otherwise, our imagination runs wild. And sadly, only 13% of the uncertainty phrases had clarifying comments. And so I think every gastroenterologist is going to very much appreciate clarifying comments to help us understand what you're thinking. So this one study then took all this data, and they had some focus groups in trying to find maybe best practices for how to deal with uncertainty. And so, surgeons felt that every slide needed to be reviewed with pathologists, and they wanted to actually look at the slides. They said maybe a phone conversation was okay, but they want to look at the slides on a shared microscope together. Which I do feel that sometimes. I feel that if I can look at something, maybe I'll understand it like you, even though I have 20 years since I went to my anatomy and physiology courses. But there is a sense of security I feel when we can look at slides together. I don't know how much it changes from your point of view. Others, though, really focused on more of, thinking less about this idea of grading uncertainty, this kind of favor, suggestive of, suspicious of, and kind of hemming and hawing on which word should I use, and moving more towards this idea of, what's going to be an action, actionable item. What is our threshold to pursue action? Is this worrisome enough that we think it needs to be resected? Is it not worrisome enough that we don't even need to survey it, or is it in between? And so then really kind of breaking things into just a few categories. So we'll take the remainder of this talk to go over just a few specific examples. The framework I want to think about is really the sampling and the reporting, the back and forth between GI and pathology. So the first problem I think that I see, a common issue is, is my GE junction biopsy Barrett's, right? And I know you guys deal with this because I know I send it to you. And so from a sampling point of view, you have to appreciate, we can't always identify the LES. It's not like there is a roadmap that tells us it's the LES. Frequently, when we're concerned for Barrett's, there's also a hiatal hernia because that predisposes to reflux. And then we have a hard time telling when the tubular esophagus really starts. In addition, we often don't want to make decisions if we don't have to. So if we're in an endoscopy and I know that I have 7 more cases and I'm already a little late, and I didn't finish my coffee and the Z-line looks irregular, I don't want to have to make the decision now if it's important or not. I'll just biopsy it and I'll let somebody else tell me if it was important. It's not the right thing to do, I'm telling you that, but it happens to everyone. It happens to everyone. So the problem is that biopsies in the vicinity of the esophagogastric junction with intestinal metaplasia, it could be Barrett's, it could be intestinal metaplasia of a proximal portion of the stomach. I have to admit, I didn't include this here because I couldn't quite figure out how to fit it in, but one of my favorite articles that I came across in this topic was, does the cardia exist, fact or fiction? I love that. And I never questioned the existence of the cardia, and now I do. And I think it's really a fascinating idea. And I'll probably use that for a whole talk on the fellows about whether or not the cardia exists. And so really the key here is was the tubular esophagus biopsied? Are we dealing with ultra short lesions of Barrett's, which probably don't even matter? Okay, so this is an area where I feel like the onus is more on the gastroenterologist. And so things that you can feed back to gastroenterology. One, how many specimens were available? If we're biopsying short segment Barrett's, we should be giving you at least 4 specimens. If we're biopsying long segment Barrett's, we should be giving you at least 8 segments. And if we didn't give you enough segments, feel free to tell us. You know, if I only sent you 2 segments, 2 biopsies of an irregular Z line, you know, say, hey, this is not enough for me to, you know, say this is Barrett's or not. And then give a differential, you know, for the intestinal metaplasia. Hopefully you're in a system where you can actually look at my endoscopic pictures, because it is a quality marker for us to take a picture of the entire Z line. Sometimes it's not possible because of patient issues, but we really do try. And if it's pretty obvious that we're dealing with an ultra short segment of Barrett's, there are more and more GI guidelines that are recommending that we're not even biopsy those. You know, the risk of cancer is incredibly low. On the other hand, you know, perhaps not so much in this country, but if we're dealing with somebody who traveled a lot or from another country, if you're in a different area where there's a lot more H. pylori and intestinal metaplasia, perhaps we're actually catching gastric intestinal metaplasia. And then we need to be concerned maybe about taking mapping biopsies. And so that's something that the gastroenterologist would probably not be thinking when they're doing Z-line biopsies, but maybe they actually got lucky and found intestinal metaplasia when really the issue though is gastric metaplasia. So I think the solution here is really to give feedback to GI, to really reinforce, you know, in a collegial way that we really only should be biopsying more than a centimeter above the GE junction, and how many biopsies we're giving you. And I think this can be done in the report very professionally, but I think it's also great. I mean, we have GI pathology conferences, and I think this is the kind of stuff we want to learn from pathology. Are we giving you the right information? Another problem that I come across frequently is, what do I do with a random stomach biopsy with intestinal metaplasia? And so first, sampling. So, you know, the questions that we should be asking for intestinal metaplasia are, was high definition endoscopy used? The answer for most of us is likely going to be yes. Was NBI used, narrowband imaging? Do we have photographic documentation, and was a sampling protocol followed? Now, the problem with this is that this assumes that I knew I was dealing, or I thought I was dealing with intestinal metaplasia. Most of the time, the endoscopist is not thinking of that. Certainly not in this country. Often we are seeing nonspecific chronic gastritis, and we're just grabbing biopsies for H. pylori. So it's a surprise when we get intestinal metaplasia back. And frequently, we are actually just giving you one jar that says stomach, not even breaking down antrum and corpus. Well, still, I think it's helpful, though. We need to know if there's H. pylori. I believe pathologists do this routinely, but it's just as a reminder, if you do see intestinal metaplasia on a gastric biopsy, you know, probably worth staining for H. pylori just to be sure. However, it's also true that when we are dealing with precancerous lesions or even adenocarcinoma, that H. pylori decreases in bioburden in the stomach. And so it's important for that to be conveyed to the gastroenterologist, is that, hey, you know, biopsy samples may represent false negative in the setting of intestinal metaplasia or precancerous lesions. Consider other forms of testing. And just as a clinical pearl, this is actually one area where many experts actually recommend still serology testing. Serology testing has fallen out of favor for everything else, because that obviously tells you nothing about the acute or inacute phase of H. pylori. But if you get a history of someone who's never been treated for H. pylori, they have a positive serology, and now have intestinal metaplasia, it's probably worth treating them at least once. And then it is really important for us to understand the terminology. So when you do get intestinal metaplasia, we use your action items, which you're not always able to give us, but we use these as action items. So one, the extension, if it's possible to know if it's extensive. Unfortunately, like I said, a lot of times we probably weren't thinking intestinal metaplasia, and so you may just have one jar of random biopsies. But if you can still get a sense that all the biopsies had intestinal metaplasia, and you knew that it came from both a mix of the antrum and the body, then you can maybe say with some confidence it's extensive. More likely, you're going to be able to tell us if it's incomplete or not. And the reason that these two things are important are that we use these to determine follow-up. So if there's extensive or incomplete histology, or if we can't tell, you know, if we didn't do a good enough biopsies to tell this, we actually bring them back in a year to do formal surveillance biopsies. And in the meantime, we treat H. pylori. If it's pretty obvious that it is not extensive and complete, then no surveillance is required. Okay. My patient with dyspepsia has lymphocytic infiltrate on duodenal biopsies. Is this celiac disease? All right, so back to our framework. Okay, sampling. First of all, should we be biopsying duodenums for dyspepsia? That don't give us feedback for. That'll probably irritate some GI doctor. But truthfully, we probably shouldn't. For isolated dyspepsia, it is probably not worth it. Although there is some hemming and hawing in the GI literature on if they're already getting an endoscopy, maybe do it. But it turns out that the prevalence of dyspepsia, of celiac in patients with dyspepsia is the same as the general population. So the yield is not going to be great. But again, number and location is important. So there are good studies that tell us that 4 is the magic minimum number. However, most experts recommend 6. And we know that celiac can be patchy. We know that including duodenal bulb biopsies actually really increases the yield, because I think that's where a lot of the gluten first hits the duodenum. So you see a lot of pathology there. The tricky part is, right, that's also where the stomach acid hits the duodenum. So you get a lot of peptic duodenitis there. You have Brunner's gland, so it can be tricky. And so celiac is patchy, though. So you want to get at least 2 proximal and 4 distal. And that's what we try to train our fellows in. But just be aware, if we didn't give you the right biopsies, we're setting you up for failure, or at least not at the ideal situation. And so give that feedback back. Are you aware? I mean, did we comment on if the person was on a gluten-free diet in the endoscopy report? That's very important, right? Because if you know they're on a gluten-free, if you know they're on a high gluten diet, maybe then just a little lymphocytic infiltrate is less important. If they're on a gluten-free diet, well, maybe they have latent celiac. So that's important information there. And then also, the gastroenterologist should be reviewing this, but it's always helpful to have somebody else think of it, or their serology is taken around the time of biopsies. And so usually between those things, you can put together the clinical picture and make the right diagnosis. On reporting, it's very helpful to not only comment on the number, as I mentioned, but the quality of the biopsies. I am a big squisher. I like to put as many bites as I can onto my forceps, to the point where we're actually trialing in our endoscopy lab down the street a new type of forceps that you can take 6 bites without squishing. And so we'll see how this goes. We have yet to use these, but I'm highly excited to use them for my dysplasia surveillance and my celiac biopsies. So I'm looking forward to getting some feedback on if the quality is going to be higher. But there are actually experts in the GI world who recommend, when you're doing celiac, taking 1 bite at a time. I do not have the patience to do that. I've gotten myself down to 2 bites with 3 passes. But it's hard. It's hard. It takes time. And you're just sitting there holding the scope while the poor tech is trying to get this one piece of tissue that's stuck in the biopsy forceps, and everyone's staring at this tech, and it's getting tense, and you're running late. And so it is a challenge. And then I think we really do like documentation. And I didn't put a slide on how much we like scoring systems in general, because there's too many scoring systems, but I did want to highlight that whenever there is a scoring system, we like that. I was raised in a training system that used a modified Marsh. However, I'm certainly open to using different ones. But we understand that there is subjectivity in this a lot of times. We do the same thing, though, clinically. We have scoring systems for everything, for GERD, for bloat, for clinical symptoms of Crohn's and ulcerative colitis. And those are much more subjective than yours. Sometimes you just have patients, point with smiley faces where they are, but they're very, very helpful. I think any time you can objectify something, you help us to monitor over time. And so much of what this is not one snapshot, but what is going to be happening over time. And so we do like to see the change in histologic score with the Marsh score over time. Right, the final case that we'll review is, what should I do with low-grade dysplasia from my UC patients on colon biopsies? This could easily have been an entire talk. We are going to hit this on a superficial level, but first we'll talk about the sampling. So what's important to realize, and I think most people are aware of this now, is that the vast majority of dysplasia in ulcerative colitis and Crohn's colitis is visible dysplasia. And so it's really important to know whether the biopsies were random or targeted. Most biopsies are targeted. There's studies that even go back and look at pictures of random biopsies, and we're able to determine from the pictures that they were actually probably targeted to a lesion. with the change from fiber optic cameras where you're down, looking through a pinhole to these high definition, huge, 52-inch screens, you feel like you're walking in the colon. We can see a lot. We can see a lot. And previously, there was this idea of invisible dysplasia. We couldn't see, it was just kind of this blurry red. And you just took random biopsies. And we knew that if we took 33 biopsies, that was 90% sensitive. We know if we almost, doubled that, we got 5% extra, but, that's a lot of biopsies. So the industry standard for colitis became taking, 34 random biopsies throughout the colon. But now we really have moved away. We still do that. And the most recent AGA recommendations actually still recommend random biopsies. There are a lot of people that feel that with high definition cameras, we can only biopsy targeted lesions. I don't think we're there quite yet for our society to recommend that, but I do see that as a shift probably over the next 5 or 10 years, that with high definition cameras, we will not be giving you 8 jars of biopsies to review. But it's really important that we're also giving macroscopic and endoscopic descriptions. And the terminology that's recommended, you'll notice, looks a lot like the terminology for sporadic polyps. And so we kind of had these old terms, DOLMs and ALMs, which we don't even put in our slides anymore. Our fellows don't even learn about these now because we typically just talk about dysplasia and IBD very similar to how we talk about dysplasia in non-IBD patients. Is it polypoid or is it non-polypoid? And then what are the descriptors under that? And the idea of invisible dysplasia is really the minority of dysplasia at this point. And then the key thing to realize is both endoscopically and histologically, is there coexisting mucosal inflammation? Because that is the one factor that I think is the most important in determining the outcome of the patient. In terms of the reporting, the old classification, decades old, is still used and I think preferred today. The CNIT guidelines, the IBD group that met, tried to get rid of indefinite for dysplasia, but there was a lot of pushback from that. And I personally don't think we should get rid of indefinite for dysplasia. I think that's just too mean for you to say either there is or there isn't. And the truth is that there is a clear difference in risk of progression to high-grade dysplasia or carcinoma from negative to indefinite to low. People with indefinite dysplasia do not fit quite in negative or quite in low grade with their risk. And it's okay. We can come up with a management plan for that differently. So the key questions we now ask ourselves in IBD dysplasia management are, is this a dysplastic lesion? And if the answer is yes, is it endoscopically resectable? This is it. I mean, we've gone from these really confusing algorithms and all this, is it sporadic? Is it inflammatory associated? Is it polypoid? Adenoma-like, to just, is it dysplastic? Is it resectable? That's the fundamental questions we ask ourselves. The management of visible raised dysplasia now resembles the management of sporadic adenomatous polyps, and that complete resection of a dysplastic polyp apparently does not signify a substantial risk of future colorectal cancer. Still doesn't quite get us out of this conundrum that we find ourselves in occasionally of true flat or invisible low-grade dysplasia from random biopsies. And here's where, I think these are the cases we talk about at our care conferences. We look at clinical factors. Does the patient have PSC, right? If they have PSC, much more likely to take that seriously and say, well, we should start thinking about a colectomy now. Is it multifocal? So if there's multifocal flat areas, then that's more concerning. Is there ongoing inflammation? In my experience, that's the one predictor of invisible dysplasia, is inflammation. And invisible is not really the right word. It's just that there's so many mucosal irregularities, I can't identify a polyp. So at a minimum, with flat low-grade dysplasia, we're going to do aggressive follow-up with a colonoscopy in 3 to 6 months, likely with chromoendoscopy. Okay, so you don't want to be the pathologist that, is basically like an endoscopist and just right, funny looking cells, pink and violet, clinically correlate. Because remember, if you do that, this is who you're sending that report to. These guys who are trying to take selfies with their endoscope, okay? So in conclusion, we have a synergistic relationship. We can make your lives better by giving you better samples, and you can make your lives better by giving us feedback on the samples, and we can tell you what we want in reporting, and you can give us better reports. And that is the end of my talk. Thank you so much for having me. If anyone has questions or comments or clarifications.
One of the things was, as you were going through all of your very helpful and interesting comments about how you think about how many biopsies you send. And I think about how many biopsies I see. And I really feel like I see what you're talking about from my GI colleagues, but in our practice, we have a lot of endoscopy being done at outside smaller places, usually by surgeons, sometimes by GI trained people. And so I don't know if you have any comments about working with that, or how we can maybe communicate some of that.
Yeah, I mean, that is a very interesting problem. And this kind of moves away from medicine and into the science of administration. So, you know, we have the same issue in our system, right? We technically, Health Fairview has, 40 clinics and however many hospitals, and a huge number of surgeons and some family practice doctors that are trained in colonoscopies. I mean, and the truth is, there's good studies that show nurse practitioners can be trained to do colonoscopies as well. So there's a large variety of people that are maybe outside of the GI division, where you can kind of go to the chair and say, hey, your docs are doing something weird. Can you fix it? The truth is, we've had to take a systems-wide approach for some of these things. And I think we have had a couple times where there have been errors in the system. And then we have reorganized our system as a whole to have basically a director who then can send emails and disseminate best practices through that. It's challenging when you are in more rural settings, because sometimes and what you may be saying is that you may be dealing with people that are actually not in your practice.
Clients. We call them
clients. And so, I'm not an expert on how to do that, but I think even those people ultimately would still respond well to reaching out and talking to them as a group, having, twice a year getting together to review some interesting cases, and then giving feedback about things that they could be doing better, because ultimately everyone knows that the better information I give you, the more likely I am to get a right diagnosis and help my patient. So I just think you have to kind of get back to the idea of giving feedback either in the report or professionally, collegially through a meeting. I can't speak highly enough of multidisciplinary meetings. I think that is the cornerstone of what makes our care good, is that we're able to interact with pathology, radiology, surgery all together. That is what really. Yeah, so the question was, I alluded that we shouldn't be biopsying the duodenum as much as we do. I mean, it really just comes down to, I think, the pre-test probability of celiac. In many cases, it is low. It's about 1% in the general population. I think there's kind of two lines of thinking there. There's one line of thinking that says, well, if you've already decided to do the endoscopy and you're already there, just get the biopsies. The risk of sedation and endoscopy is already there. The risk of duodenal biopsies and the general population is very, very low. The other side is that it's creating more work for a pathologist, and that is an extra finance. There are extra bills that are paid because of that. And so it's just a fine line. I think some people will biopsy every duodenum they see. And many times that is probably not the right thing to do. I don't know how to get more than that and more specific than that. It's just, it's a conundrum, and I think depends on really what you think the pretest probability is, what the indication is. Thank you very much for having me. And I'm sure the rest of these talks will have much more pathology slides so to sink your teeth into.
Great. Yeah, I really like that, because sometimes I do send out these reports and I think, okay, it's going into the ether, and what are they going to think about that? And if there's a lot of questions, then I often will call, but we don't always have time to